So hi everyone, my name is Pratt. I know many of you, I think most of you probably know who I am already, but I am currently the Chief Pathology Resident at the University of Minnesota.
Recording in progress.
Yeah, thanks. Okay, I got that. So today I want to talk about one of the most interesting cases that I actually had during my residency and what I learned from this case. And I actually saw this case while I was rotating at Hennepin County Medical Center, but it was a very complex case and it actually did come to the University of Minnesota for consults. And so the U of M had a hand in the diagnosis as well. So, I'd be curious to know if anyone does remember this case. They may or may not. It was about 6 months ago that it would have come here. And so many of you may find the format that I'm about to present in similar to what we do for CP case conferences. However, this particular case has a lot of diagnostic twists and turns in it, and it wasn't really appropriate for a CP case conference just because it was a little too long, or would have been a little too long. And it's also a really good learning case to talk about multiple different entities. So I'm going to be talking about a whole diagnostic group of entities rather than just the single diagnosis at the end. Oh, my slides are not moving forward. Oh, there we go. All right, so my objectives here are to discuss an interesting case of acute leukemia with a challenging diagnosis, to review the diagnostic components and the importance of ancillary testing, and to summarize the literature surrounding acute leukemias of ambiguous lineage, and then discuss some similar entities as well. I do not have any disclosures. So I want to start with a background of our case. So this patient is a 70-year-old male presenting with 2 months of shortness of breath, recurrent nosebleeds, easy bruising, petechial rash, and weakness. And these symptoms unfortunately coincided with his second dose of COVID vaccine, so he didn't initially seek care right away, thinking that these were just side effects from his vaccine. And his past medical history is significant for coronary artery disease, but he has no oncologic history. He has no significant family history and no significant exposure history. And his physical exam and his vitals are all largely within normal limits. So the most significant clinical lab finding in this case is an extremely elevated white blood cell count of 80,000 with 63% blasts in his peripheral smear. And this immediately worries the team for an acute leukemia. He also has a severe anemia and a thrombocytopenia as well. And a rapid FISH test is ordered to rule out promyelocytic leukemia, as is typically done in these cases, and that is negative for that translocation 1517. And so the early management for this patient includes a hematology consult. He was started on hydroxyurea due to his high white count of 80,000 due to concern for leukostasis, and a bone marrow biopsy to further characterize his acute leukemia. So these are the images from his peripheral blood. And so you can see these cells, which are most of the cells seen, or 63% of the cells seen, are large cells, and I included a neutrophil here for comparison. So these cells are larger than neutrophils, and typical mature lymphocytes would be smaller than a neutrophil. So these are atypical cells. They also have a high NC ratio, and they do just appear to be immature cells. And so these were called blasts. We did not see any Auer rods. We looked at this case very, very carefully for Auer rods and didn't see any Auer rods. And so we can't really say by morphology whether these cells represent immature lymphoblasts or immature lymphocytes or lymphoblasts, or immature myeloid cells or myeloblasts. And there was a bone marrow biopsy performed as well, and it showed this aspirate. And so again, the majority of the cells in the aspirate in the patient's bone marrow are these large cells. We can see prominent nucleoli. These cells have a high NC ratio. They really look like blasts, but they're really kind of nondescript. We don't see any Auer rods here, so we can't really definitively say whether these are lymphoblasts or myeloblasts. And this is a close-up of the core from the bone marrow. And again, we see most of the cells are these blast cells. And here I think sometimes it's easier to appreciate the nucleoli. And so we can see that many of these cells have one or even two nucleoli that are pretty prominent. So at this point, I'm going to go way, way back to our chart of hematopoietic differentiation. And many of you are familiar with this chart, so I'm certainly not going to spend time going through it. But I just want to point out that to make a diagnosis in this case, we really need to figure out which side our malignant cells are coming from. Are they coming from the myeloid progenitor, or are they coming from the lymphoid progenitor? Or can we even tell? So when we start to build our differential, we have sort of three large categories of acute leukemia. We have our AMLs, acute myeloid leukemia, which come from the myeloid lineage. We have our acute lymphoblastic leukemia, which come from the lymphoid lineage. And then we have our acute leukemias of ambiguous lineage, where we really can't put these into one or the other category. So now we can kind of fill in these diagnostic categories. So in our AML, we have AML with recurrent genetic abnormalities, AML with myelodysplasia-related changes, therapy-related AML, and AML-NOS, which includes many multiple different categories, which I'm not going to talk about right now. And then in the acute lymphoblastic leukemia side, we have B-ALL-NOS, B-ALL with recurrent genetic abnormalities, T-ALL, and NK-ALL. And then we, of course, have our acute leukemias of ambiguous lineage, and these include acute undifferentiated leukemia, mixed phenotype acute leukemia, mixed phenotype acute leukemias with gene rearrangements, and acute leukemias of ambiguous lineage, NOS. So to make our diagnosis, we need three things. We need to look at our morphology, we need to look at our immunophenotype, and we need to look at our genetics. We've already looked at our morphology, and that didn't really help us narrow the differential in this particular case. And so now I want to look at the immunophenotype, and there's really two ways to look at the immunophenotype. We want to look at the flow cytometric analysis, but we also want to examine important immunohistochemical and cytochemical stains as well. So this is the flow cytometry. This is what we had first to look at. And we can see that the majority of cells are falling in what we call the blast gate here. These are dim for 45. They are negative for CD2 and CD3. So all of these cells are going to be labeled in these red dots as I go along. So you can kind of follow this population. So these cells are negative for CD2 and CD3, which are T cell markers. They are negative for CD3, but they are sort of partially positive for CD4. Again, some partial positivity for CD7, and CD4 and CD7 are also in the T cell lineage, not particularly specific markers, but they are T cell markers. And again, CD3 negative here. These cells are negative for CD20 and CD19, which are B cell markers. And they do have some CD13, which is a myeloid marker, and they're positive for CD34, which is a marker of immaturity. They also show maybe some positivity for CD117, although at this point, this really isn't very definitive because most of the cells are really negative for CD117, but this is another myeloid marker. And again, positive for CD34. They're also positive for CD38, which can be another marker of immaturity. And so we look at our cytoplasmic stains by flow cytometry as well. And so these cells were, and now they're purple, but it's the same population of cells. These cells were positive for TDT, which is another marker of immaturity. Again, negative for CD3. This is cytoplasmic CD3. And they're negative for cytoplasmic CD22 as well, and cytoplasmic CD79A, and these are both B cell markers. And they're negative for NPO, which is, of course, a myeloid marker. So just to kind of summarize these findings, this is a CD45 dim population of cells, which is negative for all surface and cytoplasmic B cell markers. It's negative for all surface and cytoplasmic T cell markers, except dim CD4 and partial CD7. It's negative for all monocytic markers, and it's negative for most myeloid markers, except for CD13 and partial dim CD117. Again, not entirely convincing by flow. It's positive for markers of immaturity, including CD34, TDT, and CD38. So we've looked at our morphology, our immunophenotype, and we also got some, and our molecular panel at this point is still pending. So when we're narrowing down our differential, again, our morphology doesn't really help us. Our blasts did not have our rod, so this doesn't really help us narrow our differential. Our immunophenotype does help us narrow the differential a little bit. And so I want to draw your attention to how the WHO defines lineage-defining markers for each lineage. And so the myeloid lineage is really defined by the presence of MPO for the most part. But you can also have monocytic differentiation. So these cases may not show MPO, but they will show at least two of the following. So NSC, CD11C, CD14, CD63, and lysozyme. And the T cell lineage really requires strong cytoplasmic CD3 or surface CD3. And then the B cell lineage really depends on CD19 for a lot of it. So we need a strong CD19 and plus one or more of the following markers. And so those B cell markers would be CD79A, cytoplasmic CD22, CD10, and PAX5. Or if we have weak CD19, we need at least two of these markers. And the WHO actually also mentions that you can have negative CD19 with at least three markers or at least three of these markers shown. However, these cases are extremely rare. So our case doesn't satisfy any of these requirements based on the flow cytometry that we've seen so far. So we can go back and kind of narrow our differential a little bit. So we're able to exclude some entities, but we do have to keep some entities on our list here. So any of these cases with any AMLs or ALLs with recurrent genetic abnormalities that are defined by those genetic abnormalities, since we don't have our genetic information back, we can't exclude those diagnoses, because if those genetic abnormalities come back, then that would classify the diagnosis. We also have to keep one more differential on, or one more diagnosis on our differential here in the AML category, and that's the what was previously known as M0 or AML with minimal differentiation. I'll talk about that in a minute. But really what we're sort of, I didn't add that yet. What we're really looking at here now, or what we're thinking about here with our case that doesn't have any lineage defining markers, is this category of acute leukemias of ambiguous lineage, and especially acute undifferentiated leukemia. So these are kind of the things that are left on our differential. And so for this M0 or AML with minimal differentiation, these cases don't necessarily show definitive myeloid lineage, but they do show at least two markers of myeloid differentiation. And those markers would be CD13, CD117, or CD33. So in our case, by flow, we have CD13, but we don't really have the other two. We were not convinced by the flow finding of CD117 in this case. So this is really at the top of our differential right now. And so the next thing I want to talk about is the chapter in the WHO regarding the acute leukemias of ambiguous lineage. And this includes 4 diagnostic entities. And really this top one is the one on our differential. But I think it's important, and I'll talk about why in a second, but I think it's important to really be able to distinguish these two sort of categories of disease, of acute undifferentiated leukemia and mixed phenotype acute leukemia. So I am actually going to talk about all 4 of these entities. So this chapter in the WHO was added in 2008. It describes acute leukemias that show no evidence of differentiation along a single lineage. Diagnosis in these cases is very dependent on the immunophenotype. These leukemias are fairly rare. They account for less than 5% of leukemias. They are more commonly seen in adults. And importantly, these cases that have defining molecular alterations in AML and ALL, as I mentioned previously, would be classified by their molecular alterations. So they would not be classified in these cases or as these cases. So I lost my mouse here. And then also the therapy-related AMLs, the AMLs with MDS, and the CMLs in blast crisis, which can also show up with mixed phenotype, and I'll talk about what that is in a minute. Immunophenotypes, those would be defined by these categories. So they wouldn't fit into acute leukemias of ambiguous lineage. They would be defined by the fact that they were therapy-related, they have MDS features, or their underlying process is CML. So I'm going to start with acute undifferentiated leukemia. And these are cases that express no specific markers for lymphoid or myeloid lineage. In these cases, the flow cytometric analysis and the IHC may need to be performed to rule out certain entities. And these entities include plasmacytoid dendritic cell precursor neoplasms, NK cell precursor neoplasms, basophil precursor neoplasms, and of course, non-hematopoietic tumors, depending on what we see in each case. This is a very rare entity. Its relative incidence is less than 1% of acute leukemias. And these cases typically show morphology of undifferentiated early hematopoietic precursor cells. So they're typically small to medium-sized blasts, high NC ratios, and conspicuous nucleoli. The cytochemical stains are negative. The immunophenotype is defined by the flow and the IHC and shows no more than one marker for any given lineage. And the lineage defining markers are not present, importantly. These cases often do express markers of immaturity like HLA-DR, CD34, CD38, and TDT, and they may show weak expression of CD7, which our case did. So I just bolded the ones we saw in our case to kind of show you that this does match pretty well with what we saw. So there have been some studies looking at the prognosis in these cases and trying to establish an appropriate treatment. There was a study published in 2013 that looked at 16 adults with acute undifferentiated leukemia and found overexpression of several genes with known prognostic impact, and those genes are listed here. And the study compared the use of ALL regimens and AML regimens in these cases and showed possible survival, improved survival with ALL regimens. However, the findings weren't statistically significant. So this is a picture from that paper, and you can see the ALL does look better than the AML protocol when used in these acute undifferentiated leukemia cases, but the P value is not significant here. But that could be because the sample size was pretty small. The paper also showed that these cases have overall poor outcomes. And then there was another meta-analysis in leukemia research that I found that was published in 2020, which looked at obviously many, many more cases and just showed that it had an overall poor prognosis, but was a little bit better in kids. And so this is from that paper. So this is kind of interesting. So in adults, this is comparing acute undifferentiated leukemia, which is the green line here, with acute myeloid leukemia, which is that sort of burnt orange. And then acute lymphoid leukemia, which is blue. And you can see that acute undifferentiated leukemia was statistically significantly worse than the other two. And the 50%, so about 50% of patients have an overall survival of about 9 months. So it's pretty poor survival for adults. But for children, it is actually significantly better. And here again, the green is the acute undifferentiated leukemia, the burnt orange is AML, and the blue is ALL. So you can see that in kids, AULs did about the same as ALLs and actually pretty significantly better than AMLs. And the overall survival was much better. So here, more than 80% of patients have actually a longer than 5-year survival in acute undifferentiated leukemia in children. So the other kind of group of these diseases falls under this category of mixed phenotype acute leukemia. So there's just mixed phenotype acute leukemia, and then there's a couple that are defined by their genetic abnormalities. And so I'll talk about those as well. But I'll start with just the category of mixed phenotype acute leukemia. And so these cases co-express lymphoid and myeloid differentiation. And the lymphoid differentiation can be either B or T cell differentiation, or rarely it can be both. And these cases are rare, and they account for about 4% of acute leukemias. And there are two kind of overall scenarios that fall into this category. And one of these was previously thought of as biphenotypic leukemia. And this is where you see two different lineages. So actually defined lineages on the same population of blasts. And so this typically requires flow cytometry. And then the second scenario is where we see two or more populations of blasts that fulfill criteria for separate lineages. And these cases were previously called bilineage leukemia. And so both these biphenotypic leukemias and bilineage leukemias fall into this category. And they're kind of two different scenarios, but they are both mixed phenotype acute leukemia. So one other thing that I want to mention, so when we look at acute leukemias, in order to call something an acute leukemia, we need at least 20% of the nucleated cells to be the malignant population of blasts. However, in these cases, because we've got more than one population, I just want to make it clear that we don't need at least 20% of each population. We just need 20% of blasts as a whole, essentially, to call this an acute leukemia. And so if you've got two populations, they can be added together to make that 20%. So this is an example from the literature. I added in a couple of these because these are pretty rare cases, and it's nice to see examples. And so this is from Leukemia published in Leukemia in 2010, and this was a case that kind of fulfills that first criteria for an MPAL. And so here in the morphology, We can see that a lot of these blasts are present, but they're kind of nondescript again. We might be able to kind of pull out two different populations here by morphology. It's kind of tough, but some of these kind of look a little bit larger, maybe a little bit finer chromatin, and some are a little bit smaller, but they still kind of appear to be sort of blast-like cells. So maybe there's kind of two different populations of cells here. But the flow is really where the money is here. And so we can see that this is one population of cells by flow, and these cells are positive for MPO and positive for CD79A. And MPO, remember, is one of our lineage-defining myeloid markers. CD79A, along with CD19, would be enough to say something is of lymphoid origin. So these are CD79A positive. They're also CD10 positive and CD19 positive. So now we've already got the B cell lineage defining markers as well. So now we have both myeloid and B cell lineage. They also show us here that these cells are positive for TDT, which is a marker of immaturity again, and they're negative for the T cell marker CD3 and CD5, and positive for another marker of immaturity, CD34. So this is an example of that second scenario that I talked about, just to kind of show you one of each. And so in this case, I'm going to draw your attention to two different populations of cells. So we're going to start with these light blue dots here. And so this population of cells, positive for CD45, it shows positivity for CD3. It shows negativity for CD15 and CD117. And remember, CD3 is an important marker of T cell origin, and 117 and 15 are important markers of myeloid origin. So we're looking at a T cell lineage here. These cells are negative for MPO, again, negative for myeloid defining markers. They are positive for a couple more T cell markers, CD7 and CD2, negative for CD4 and CD8. They're positive for CD71, but negative for CD33, which is again a myeloid marker. And again, they're positive for this marker of immaturity, TDT, as well. But we've also got this secondary population of cells in dark blue here. These cells are positive for CD3 again in this case, but they're also positive for CD15 and positive for MPO. Oops, sorry about that. And they're positive for CD117 as well. And these are all myeloid defining lineage markers. So now we've got a population that's also myeloid. And so I'll just quickly go through the rest of these, but these are negative again for the T cell markers, positive for CD33, which is another myeloid marker, and again, positive for TDT. So these cases do often show a dual population of blasts by morphology, and I have a couple pictures here to kind of show that. So often we do have large myeloid blasts with ample cytoplasm, which can show granulation. They might have monocytic features, so blue-gray cytoplasm, some deeper nuclear grooves. And then we can have a secondary population of smaller lymphoid blasts as well. And so here on the upper picture here, you can see this is a good example of two different populations of cells. We've got these larger cells, sorry about the color being so dark, but we do have larger cells with what you'll have to take my word for is finer chromatin, because it's really hard to see in this picture, I know. And then we've got kind of smaller cells with also a high NC ratio, but more sort of lymphoid looking cells. And then down here, I just wanted to show what these monocytic features would look like. And so these are kind of more monocytoid looking cells. We've got more of this ample blue-gray cytoplasm and some deep nuclear grooves here. So these cases have a poor prognosis, and the poor prognosis does depend on age and cytogenetic analysis in these cases as well. So a couple studies I pulled from the literature. There was a study out of St. Jude's in 2009, which looked at both B myeloid and T myeloid mixed phenotype acute leukemia groups and showed that they were similar to each other and similar to AML in children, but worse than ALL in their prognosis. There was a study in 2015 published in Leukemia Research. This was a meta-analysis, so looked at a lot more patients. And they showed that the prognosis depends on age, and the outcomes are poorer in their whole group of patients, which included adults in both AML and ALL. And then there was a study in the Annals of Hematology in 2021 looking at 102 mixed phenotype acute leukemia cases in both adults and children again. And they actually looked at treatment a little bit again, and they also saw, as we saw in acute undifferentiated leukemia, that ALL treatment may actually be better in these cases than in AML treatment. So now I want to go through the two categories that have recurrent genetic abnormalities quickly, because it's important to note that these cases are defined specifically with their molecular abnormality. And so there are mixed phenotype acute leukemias with T922 or the BCR-ABL translocation. So these cases would fulfill the criteria for MPAL, which we just talked about, and also have blasts with BCR-ABL rearrangement. Typically, these cases have the P190 fusion transcript, and if the P210 transcript is seen, then it's really important to carefully rule out CML because, again, and I think I mentioned this previously, but CML can show up in blast crisis and actually show up with two lineages of blasts, but those cases are still considered CML, although the WHO says it's important to note that there are mixed phenotype blasts in these cases, but they are defined as CML. So these cases, these MPALs with the T922 translocation, are relatively rare, again, or actually very rare. They account for less than 1% of acute leukemias, and they are, again, more common in adults. They do show a dimorphic blast population, again, similar to what we've seen previously. The immunophenotype is usually B myeloid rather than T myeloid, and many of these cases show complex karyotypes. And the prognosis is typically poorer than for other mixed phenotype acute leukemias. And recent studies have shown some promise using TKIs in treatment for these cases. So I just want to show you, this is one graph from one study that I pulled that looked at, so this was published in 2015 in the European Journal of Hematology, and it was a collection of cases of Philadelphia chromosome positive B-ALL cases and Philadelphia chromosome positive mixed phenotype acute leukemia cases. And these cases were both treated with TKIs. And they noted that with treatment of TKIs, the prognosis of both of these two groups was similar to each other. But in the literature, the Ph positive mixed phenotype acute leukemias, seen without the TKI treatment typically have a much poorer prognosis. So this does suggest that, it's not definitive evidence, but it does suggest that TKIs may be beneficial in these cases, as they are in PH chromosome positive BALLs. So that might be one avenue of treatment. So the other diagnostic category defined molecularly is this mixed phenotype acute leukemia with KMT2A rearrangement. So again, these cases have to fulfill the criteria of an MPAL, but they also have a KMT2A rearrangement with several different fusion partner genes, and I listed a bunch of them here. These cases are very rare. They are more common in kids and especially in infants. And this is similar to what is actually seen in ALL and AML with KMT2A rearrangements. Those cases also have a tendency to show up in infants as well. And the morphology in these cases, again, we can see a dimorphic population, often with monoblastic-like cells and lymphoblasts. Prognosis is poor in these cases as well. So our last category in this chapter is acute leukemias of ambiguous lineage. And I don't have a separate slide on this. I just want to mention that this is an extremely rare entity. And it characterizes leukemias that don't fall into any of those other categories. For example, a leukemia that it does express some myeloid and some lymphoid markers, so more than would allow it to be categorized as an acute undifferentiated leukemia, because remember, we can't show any more than one marker for each of those lineages for it to be an acute undifferentiated leukemia. So it has to show, more than would be able to be defined that way, but also not be specific enough to be diagnosed as an MPAL, basically. And so it's really a diagnosis of exclusion. And with the comprehensive flow panels that we have now, many cases that were previously diagnosed in this category are probably able to be reclassified. So it's probably pretty rare that this would actually be the diagnosis. And there's really not enough cases in the literature to suggest prognosis or treatment in these cases. So I want to go back to our case because we did discuss our thoughts on this case with the clinicians before we had all of our information back. And this is pretty common. Clinicians, with an acute leukemia, they really are anxious to get this patient started on treatment. And this did happen on a Friday, of course. And so they really wanted some information before the weekend so they could get going on treatment with this patient. And so we did tell them, we don't have all of our IHC stains back. We might, the diagnosis may change. We don't have our genetic information back, which could also change the diagnosis. But right now, we're thinking this is probably an acute undifferentiated leukemia. And based on the literature that's available, which we looked at, and I just showed you, they thought they would start, or they did start, an ALL-like treatment regimen for this patient. And also almost immediately, over the weekend even, they saw some clinical improvement in this patient. However, we did actually on Monday get our IHC stains back on the bone marrow core. And I'm listing here the markers that we saw that were positive and the markers that we saw that were negative. And some of these are actually pretty interesting. So our positive markers, we already knew that CD34 and TDT, which are markers of immaturity, were positive by flow. And so that doesn't really surprise us. CD117, which was not really definitive by flow, was actually positive by IHC. So that was interesting. CD7, we had seen that positivity by flow already. And so that wasn't entirely surprising. And then CD123 and CD4, which we look at for plasmacytoid dendritic cell precursor neoplasms, were also positive, but they were so partial that they weren't really definitive for that entity, and they kind of ruled that entity out of the diagnosis. So those were actually helpful, even though they were positive. And then we had a bunch of markers that were negative as well, and most of these we have talked about already in our flow, so I won't go through all of them. But PAX5, which is a B cell marker that can sometimes, help distinguish something as B cell by IHC, was negative, so that didn't help us. And again, MPO, which is the main myeloid defining marker, is negative. So the ones that were really interesting were these three. And again, CD117 is a marker of myeloid lineage. So this now gives us two markers of myeloid lineage with our flow and our IHC. And then I've talked about how these two help us rule out that neoplasm. We also got our cytogenetic analysis back, which was positive for a +13. And many of our diagnostic entities in the differential can have or are even associated with a +13, but it's not really specific for anything. So it doesn't really help us narrow the differential at this point, but it's important to note. So again, if we go back to our diagnostic tree here. So now we've got two markers. We've got CD13 and CD117. These are two myeloid markers. And so now we can't really say this is acute undifferentiated leukemia. And we actually move into this category of what was previously known as M0 or AML with minimal differentiation. So I just want to refresh everyone's memory. So these are the categories in the WHO that are acute myeloid leukemia NOS. And so there's many different categories. And the one that we're really thinking about here is acute myeloid leukemia with minimal differentiation, which was FAB classification M0. So I'm not going to talk about the rest of these, but I will talk about this one. So this diagnostic entity describes cases that show no definitive morphologic or cytochemical evidence of differentiation, but show at least two markers of myeloid lineage. These cases are rare, again, like all of the other cases I've talked about so far. They do account for less than 5% of all AML cases. And patients are usually infants or older adults, interestingly. And clinically, these cases present with signs of bone marrow failure, so typically cytopenias, but they can also present with leukocytosis and circulating blasts, as we saw in our case. The morphology of these cases show medium-sized blasts with dispersed fine chromatin, agranular cytoplasm, and variable basophilia. However, the blasts can also be small with condensed chromatin and inconspicuous nucleoli. The marrow is usually hypercellular, as we saw in our case, and the cytochemical stains in these cases are negative. So the immunophenotype is very important in this diagnosis. Most of these cases do express early hematopoietic antigens, so CD34, CD38, HLA-DR, markers of immaturity, which our case expressed a few of these. These cases do typically lack myeloid and monocytic markers, and so the monocytic markers that I mentioned previously, but I'll mention them again, are 11B, CD14, CD15, CD64, and CD65. And then myeloid, the important marker to think about is MPO. And so that's negative in these cases. These cases do express at least 2 myeloid-associated markers. So while they're not myeloid-defining markers, they're myeloid-associated, and those are typically CD13 and CD117, but many of them can express CD33 as well. And then they often express TDT and CD7 as well, and they lack the B cell and T cell cytoplasmic markers, of course. Oh, and I just highlighted the 2 that were important in our case as distinguishing this case as an acute leukemia of minimal differentiation. So the most common cytogenetics we see are really complex karyotypes in these cases. We can see unbalanced chromosomal abnormalities, often a loss of 5 or a deletion 5q, a loss of 7 or a deletion 7q, an addition of 8 and a deletion of 11q. And many of these cases do or have been shown to harbor a RUNX1 mutation. However, this is now its own provisional entity in the WHO. So if we were to see a RUNX1 mutation, we would have to reclassify this as AML with mutated RUNX1. 16 to 22% of these cases do show a FLT3 mutation. So there was a study published in Modern Pathology in 2018 that looked at 92% of acute undifferentiated leukemia cases and acute myeloid leukemia cases with minimal differentiation, and saw no difference in prognosis between these 2 groups. And so while our diagnosis changes, our prognosis for this patient hasn't really changed much. These are both entities that typically show a poor prognosis. And this is from that study. So back to our case, we now get our molecular diagnostics report back, and we do see some alterations of known or potential pathogenicity, and the really key one here is RUNX1. But we also see an ASXL1, G646FS, BCOR, and a WT1 mutation as well. But RUNX1 is really going to change our diagnostic category. And so, as I mentioned a minute ago, that is actually its own provisional entity in the WHO, which means that this definitively changes our diagnosis to AML with recurrent genetic abnormalities. And I'll just remind you what those are. Obviously, I'm not going to go through all of these, but these are the AMLs that are defined by their genetics. And particularly this case is AML with mutated RUNX1 now. So our diagnosis has changed once again. So the last entity I'm going to discuss today is AML with mutated RUNX1. So this is a new provisional entity in the 2017 edition of the WHO. By definition, it fulfills criteria for an AML and NOS. About 40% of these cases actually would have otherwise been described as falling into the M0 or AML with minimal differentiation category. So it is actually common for these cases to have that immunophenotype. We also need to make sure to exclude any cases that have other recurrent genetic abnormalities in which or cases in which the patient has previously had therapy. So those would be therapy related. Cases with MDS related changes. So those would be in its own category as well. So RUNX1 mutations are seen in 4 to 16% of AML cases. So it's fairly, fairly common, I guess, finding. Frequency is higher in older adults and in men, interestingly, too. So our older male fits right into this category. They are commonly associated with radiation exposure and prior alkylating agent chemotherapy. However, many patients present without a known exposure history. Morphologically, these cases often show monocytic or myelomonocytic features, and the immunophenotype often includes expression of CD13 and CD34, with variable expression of CD33, MPO, and monocytic markers. And this is an image showing you that, again, kind of monocytic-like look with these blast cells that just have a little bit more chromatin. I know the color's a little bit funny here too, but this is sort of a bluer gray chromatin, and they do have deep nuclear grooves. So this is kind of more along the monocytic line or myelomonocytic differentiation feature, I guess. Did I go the wrong way? No, I didn't. Okay. Yeah. So cytogenetics, the most common karyotype abnormalities are +8 and +13, which we saw in our case. And then molecularly, there are some cooperating mutations too. And so these include ASXL1, which we saw in our case, but also KMT2A, FLT3, IDH1, and IDH2. And some studies have actually shown a worse prognosis in cases with RUNX1 and ASXL1 mutations, which is what our case had. There are some patients with germline RUNX1 mutations, and actually about 30% of cases presenting like our patient did will end up having a germline RUNX1 mutation. There's also, for patients that do have a germline RUNX1 mutation and may not have necessarily presented in AML or MDS, they do have an increased risk of AML or MDS, and about 40% of them will develop one of these entities. A RUNX1 germline mutation is also associated with autosomal dominant thrombocytopenia and dense granule platelet storage pool deficiency. And the prognosis in these cases is poor, and there are ongoing trials looking at potential therapeutic targets. So I just thought this timeline was kind of interesting. And so this shows our RUNX1 gene sort of being first described in 1991. And then being shown to be associated with AML pretty soon after that, 8 years later, I guess, in 1999, but still quite a while ago. And so it's been known for a while to be associated with AML, but it was just recently added as its own entity with its own prognosis. And potential therapeutic treatments are being investigated currently. But you can see it's also has been shown to be associated with other hematopoietic malignancies over the years too. And so this is the last kind of point from the literature that I'll show. And this table just shows that there are a lot of different ways in which RUNX1 mutations are thought to lead to leukemogenesis. And so these are all kind of different mechanisms of that that are being looked into and are being used as potential avenues for learning more about this entity and also potential therapeutic treatments. And one more recent paper I saw was looking at and showed some promising results from mouse models looking at specifically this BCL2 inhibitor venetoclax in these patients. So the last thing I'm going to do is go back to our patient because there is actually another little twist in this case, surprisingly. And so after this patient was started on therapy, they followed up with more peripheral blood smears. And this is one of the peripheral blood smears that we saw after initiation of treatment. And these new smears show kind of a different morphology in the population of cells that are dominant in this patient. So before we were seeing really kind of undifferentiated blast-like cells, now these cells are, they still, fall into the category of blasts, but they're a little bit smaller. They have these nuclear grooves. They have more cytoplasm. They're a little bit monocytic in the way that they look, or myelomonocytic. And so I'll just add, this is from our original peripheral blood smear. So you really can see the difference here. The chromatin is even a little bit more clumped. They just look a little bit more differentiated along the monocyte lineage than what we saw previously. And so we were wondering, are these even the same cells? Is this the same population? It's just kind of odd that they look so different. And we also did flow cytometry on these cells as well. And these cells are now, where they were falling in the blast gate before, are now falling in the monocyte gate. So that's kind of interesting. And then they also show some CD14, which is a monocyte marker. They show some CD14 differentiation as well, which is kind of, again, interesting. So, we're trying to figure out how do we say specifically that these are from the same clone. And so one thing we thought was, okay, well, our trisomy 13 can actually be useful now because we can do FISH on these peripheral blood leukocytes and look for that trisomy 13. And that's what we did. And we did see trisomy 13 in 82% of the interphase cells here. And so these are cells from the same clone, the patient's original clone. But interestingly, the treatment seems to have initiated some kind of differentiation in the morphology to make them a little bit more monocytic looking. So that's the end of my presentation. I do have quite a few references here, so I won't bore you, but there were a lot of studies to look at in this case, or in this group of entities. And I do want to acknowledge some people too, of course. So I want to first thank the staff at HCMC. I know they're probably not on this, listening to this presentation, but I should thank them anyway. So Dr. Fink was the one that particularly looked at this case with me. And he helped me kind of work through this case. And I think this case was an extremely good learning case for me in terms of learning about this interesting group of entities. He also helped me collect and save the images for this presentation. So I want to thank him for sure. And Dr. Linden and Dr. Yohe both helped me, and actually Dr. Dolan as well, both helped me when I was putting together this presentation. So I, of course, have to thank them for that. And also, of course, the faculty and staff in the hematopathology division of the Department of Lab Medicine and sorry, getting a little tongue-tied. The Department of Lab Medicine and Pathology at the U. I want to thank all of them too for all their mentorship and guidance over my 4 years here. Dr. Dolan and Dr. Johnson, just for their leadership of our residency program, which I've really seen, especially as a chief resident. They just do an amazing job as leaders for us, and they do a lot for us. And then Maggie and Gabby also for their dedication and guidance and assistance. And again, I've really seen how much they do for us as a chief as well. And then Dr. Crossan and Dr. Asilla for their kindness and their mentorship, especially at the beginning of my residency. And then all the wonderful faculty and staff in the AP and CP departments that I've worked with, including our amazing PAs, our cytotechs, our histotechs, and our lab techs. And of course, my fellow residents who are all wonderful, and the fellows here at the U of M too, some of which were my fellow residents just a year ago. So that's the end of my talk. So I do have some time for questions. So I will open up the floor for questions now.
Yeah, I have a question. Thank you very much for such an excellent presentation. Even for somebody that is not a empath, you know, I could follow your presentation nicely. So 2 questions. The first thing was from the peripheral blood, and I don't know if I mix this one up, but the cytogenetics in the peripheral blood is completely different from the RONS X thing that came to be. So how does that factor? And
yeah, so we didn't actually do molecular analysis on the peripheral blood. We just did the FISH for that trisomy 13. Okay. And I glossed over it quickly at the beginning, but we had seen that same thing when we did our karyotype analysis on the original leukemic cells. We saw that plus 13. And I apologize, I did kind of mention that really quickly, but that was sort of the easiest way to make sure these came from the same clone, was to do FISH analysis looking for that plus 13 in these cells rather than do a full molecular analysis.
Okay. So actually I was talking to you about the first peripheral blood before.
Oh yeah, sure.
I think it was a 1517 or something that was.
Oh yeah, yep. So at the very beginning, I can go back. So basically all of the acute leukemias that come in, if there's any question that they could be acute promyelocytic leukemia, we do FISH for 1517 because that's something that needs kind of immediate attention and treatment, and can be really, the outcome can be really changed with immediate treatment. And so that was just sort of it came with the initial set of clinical, sorry, I'm just trying to find the right slide here. Yeah.
Oh, okay. It was
sort of the original clinical presentation and the original clinical findings, and that's why I included it there. But it was just a rapid FISH. We didn't look for any other translocations at that time.
Oh, okay. Yeah, sorry, I actually read that as positive, so I was wondering how it came in. Okay.
Oh, yes, yes, that one was negative. Yep.
Yeah, thank you. My second question quickly is CD117. So yeah. I have been taught that this is a marker of progenitor stem cell. But you seem to be using it as a T-cell marker in this context.
So it's actually, it does show up in immature myeloid cells, but it is a marker of myeloid differentiation. So of cells that are going down that differentiation pathway to be neutrophils. Typically, those will show this CD117. So we see it in sort of immature neutrophils or immature myeloid cells, but it does count as a marker of myeloid differentiation. And actually I had included a paper and then I kind of took it out at the last minute, but there's pretty good evidence in the literature that this is a very strong and useful marker, both IHC and flow, to use as a myeloid marker. So not necessarily lineage defining, but something that shows you that at least we're going down that pathway. And maybe it's better if I go back to this chart, that at least we're going down this pathway of a myeloid progenitor. But you're right that it is typically seen in more immature cells and often seen in blasts, myeloblasts.
Thank you. Nice presentation.
Thank you. Any other questions? We certainly have time for them. I think we've got another 10 minutes.
Hey, Anna, it's Dr. Dayton. I just want to echo again, what a beautifully done presentation that was. So clear, so organized, so well done.
Thank you.
And how much information you transmitted in a brief period of time. It was outstanding. I'm just curious, it seems to me that at some point, particularly when the cells, the blast cells, with confirming the plus 13 after, somewhere into therapy, showed apparent monocytic differentiation, both cytologically and by the expression of the CD14. Did you get the idea, and did you throw on a cytochemical myeloperoxidase and nonspecific esterase? Just out of curiosity.
Yeah, that is a very good question. I don't remember. I don't think that we did. I should have looked that up ahead of time. It was 6 months ago. I did try to kind of briefly refresh myself on all the aspects of the case, but I forgot to look at whether we did that in our.
Okay, good. That's, I know that probably sounds like a gee whiz kind of thing, but it is. But
yeah.
It is. It would have made for an interesting twist, and I suspect that you would have put it in the presentation.
Yeah, I mean, if it certainly wasn't done and positive, I'll say that. But yeah, I can't remember. Yeah,
I realize we're pathology grand rounds, and again, beautiful presentation, very well done. Just out of curiosity, once the Runx Runx one was determined, and the diagnosis essentially was clarified for the clinicians.
Mm-hmm.
Did they switch over to, did they add anthracyclines? Did they try venetoclax? And how did this patient do? I suspect he did very badly.
Yeah, I tried to look at further information for this patient, and I'm not sure if he transferred care or something, but I actually lost, there wasn't a lot of information on what they did after this. So unfortunately, I don't know the answer to that. I wish I did. And that, I think, because it sort of happened as I rotated off out of HCMC. And so it just had to look back and try to find it in Care Everywhere, but there just wasn't a lot of information on it. So I'm not sure why, where he's getting his care now, or maybe it just didn't transfer over. But unfortunately, I don't have the answer to whether they changed I was wondering that too, and it would be interesting to know if they changed their treatment regimen at that point. But yeah, I don't know the answer to that.
Again, thank you so much. It was beautifully done. You really clarified what seems very complicated, and just to reinforce, the reason I asked the questions, to reinforce it really does matter to the clinicians, because the evolution of our ability to clearly define these subsets of leukemia leading to more directed therapy has improved outcomes, has required us to be more precise in our classification, which has improved treatment, which has improved. So it's been a cyclic process going forward that is beneficial, and it is what we do. So thank you for doing this. And you and I thought Dr. Khalifa was trying to pull you into, yes, CD117 is a marker of myeloid maturation, but obviously we see it expressed in other neoplastic processes, specifically GIST. And so I think that's why he was pulling you into that.
Okay. Process. Yes. Okay. Of course. But yes.
Just for other trainees on the call. Thank you so much, Anna. That was great.
Yeah, thank you, Dr. Dayton. Yeah, and thank you for clarifying that. Sorry, Dr. Ade, I think I misunderstood your question, but yes, of course, CD117 is also something we look at in other more surge path entities. So just as a common one that we talk about with CD117. But in this case, in the heme path world, we think of it as an early myeloid marker.
I think since there's no more question, I think I just want to say something about the last three trainees presentations, starting with Monica, Ira, and now you. And I think we as a department should congratulate ourselves, for having our trainees present this excellent, engaging discussion. So congratulations to the three of you. Just wanted to say that.
Thank you.
I actually have a real quick question. This is Amy Beckman. Hi, Anna. Really nice talk on a very complex subject. I am going to ask you a really nitpicky question, which maybe didn't come up in your research, but if it did, I'd love to hear about it. So I'm wondering specifically about the marker CD123, which we sometimes use as a to look for and rule out the possibility of blastic plasmacytoid dendritic cell neoplasm, which would have put you in a completely different category.
Yep.
But it's a marker that's frequently expressed at lower levels on AML. And I wonder if in your reading, other than that, I guess I have to admit, I don't know very much about this marker. And I wonder if in your reading, if you discovered anything about whether CD123 can be used as a marker that's at least, it's obviously not lineage defining, but whether it's something that's tends to be associated with the myeloid lineage.
It didn't actually come up in the WHO as one, and in the other studies that I sort of went to from the WHO, it didn't come up as a myeloid lineage marker, but it was often done in case reports and shown, and it did seem to be commonly sort of partially positive in a lot of those cases, which was kind of interesting, even though they weren't cases of plasmacytoid dendritic cell neoplasm. So yeah, I wonder if it actually is possibly can be seen, and maybe someone else can answer this question, obviously, that's on the call and not me.
So it's definitely a marker seen in AMLs, but at a level that's less intense than it would be seen in blastic plasmacytoid dendritic cell neoplasm. I just more wondered whether it's seen in lymphoid leukemias or in mixed phenotype leukemias.
Oh, I see.
I'll have to look that up on my own. Thanks.
Yeah, I don't know the answer to that. Yeah, I'll have to look that up too.
Okay, anyone else?
I have a question, Anna, regarding the regarding the apparent monocytic conversion of the blast. Do you know how was the patient treated before that?
Yeah, so that was after their treatment with the ALL regimen. So I had that in one of these.
Oh, so it was after the ALL regimen.
Yep.
Okay, I wondered if it was after specific treatment. Sometimes that happens.
Were you wondering, Artek, were you wondering if it was because of the steroids, the Decatron?
I was actually thinking about venetoclax because Dr. Pratt mentioned venetoclax in the context of Ranks One, and I was wondering if they used it.
As far as I know, they hadn't used it yet when that peripheral blood was done. But I don't know if they switched to it later. But as far as I know, that hadn't happened yet.
Yeah, and regarding the earlier discussion about the markers, it's important to remember that these are receptors with certain functions, and we just use them as markers, but that's not what they are for. So CD117 is a receptor for stem cell factor, and CD123 is a receptor for interleukin-3, and various cells can express these receptors for various reasons. For example, aberrant expression of CD123 can be seen in many cases of B lymphoblastic leukemias, and we actually have it in our what we call advanced BALL2 lymphocytometry lab as one of the marker of aberrancy in B cell recursions.
Okay, we're going to close for the day. I agree with Dr. Ade, what he said about our residents. We've had excellent presentations. We have some more upcoming. Next week, we will have Dr. Jesse Siegmiller presenting So let's thank Anna today for a good job, and we will see you all next week. Actually, this afternoon with our HLA candidate. Be well, everyone. Good job, Anna. Bye-bye.
Thank you, everyone.